Welcome back to the Chief Healthcare Officer podcast show. I'm Dr. Fatih Mehmet Gül, your host, and today we're joined by a dear guest who argues that healthcare's biggest crisis is not just a clinical one, it's a math problem. Mohan Giridharadas is the founder and the CEO of LeanTaaS, and I have been actually hearing him in so many different podcast shows. And also, I read almost half of the book, Better Healthcare Through Math. I was fascinated, and I just wanted to have him in my podcast show. And thanks to him, he gave me time from his busy calendar. Mohan, thanks for joining me today.
Dr. Gul, thank you for having me. It's nice to be here.
It's my pleasure, sir. Mohan, you have a very unique journey. You went from optimizing the global supply chains and then the factories at McKinsey, and then you moved to the high stakes world of healthcare. So, could you please introduce yourself to our audience and tell us what was that moment of impact? And several times you say, aha time, when you realized your engineering brain could actually save lives?
I wouldn't go quite that far. That's saving lives is something trained physicians should do. I started out as a software engineer. I was at Intel and then I was at Mentor Graphics, and I decided to go to business school. So I went to Stanford and then I joined McKinsey coming out of business school. I viewed McKinsey as something that you do for a few years after business school, much like residency is something you do for a few years after medical school. So my plan on joining McKinsey was I would do it for 2 or 3 years and then I would start a software company. That was something I always wanted to do. I ended up spending a long time at McKinsey, 18 years. And I was fortunate that I got to work with the most sophisticated clients who are operationally very complex. Think of airlines, logistics, manufacturing companies, back office banking, large global iconic companies who are McKinsey clients. And I saw what it took to do operations at high complexity and at scale. And I ended up leading the lean manufacturing practice in North America, the lean service practice in North America, and then went to Asia and did that as well. And so I found that operations at scale was fascinating to me. And what I wanted to do in my software company was deliver the magic of a lean transformation, but instead of doing it with consulting, do it on a software platform. And so I chose to call the company LeanTaaS for lean transformation on a software as a service platform. That became very hard to explain. So nowadays, when people ask me, how did you name the company LeanTaaS? I say, look, if you allow a guy with a 12-letter last name to name a company, you'll get something complicated like LeanTaaS. You won't get something elegant like Netflix or Google. That's why you get that. As far as the aha moment for healthcare, initially the idea of lean transformation on software, on a software platform, was industry agnostic. So our clients were everywhere. Flextronics, Google, Home Depot, PNC Bank, Clorox, they were all our clients. And in every case, we absorbed data, did something operationally sophisticated, like optimize inventory levels, optimize flow, and returned it on a web-based application. That's what the concept was. And then we got a break. Stanford, the guy who ran cancer services at Stanford, is an ex-GE guy. So he understands operations, he understands machines. I was sitting in his office. This is back July of 2013, so 12 plus years ago. And he asked me a rhetorical question. He said, answer me something. Why does my infusion center look like a ghost town early morning and late afternoon? It's empty. But in the middle of the day, it's like a train station. It's chaos. The chairs are full. The patients are upset. The waiting rooms are bursting. And this happens every day. In a factory, we never tolerate that. We level load and we make it work. So why can't we level load it? I hadn't done a lot in healthcare, so I thought, how hard can it be? Someone sits in a chair, you connect a pump to the drugs, and they leave in 2 hours. So it's easy. So I said, yeah, we'll solve it. 3 or 4 months, it'll be done. Turns out it's a hard problem. Oncologists practice different days of the week. Pharmacy hoods are constrained. Every chemo dose has to be custom built. Patients come and go. The regimens are different. Some are 1 hour, some are 8 hours. patients are constantly changing, and it's a very, very hard math problem. But we solved it. And when we solved it, it was like lightning in a bottle. Wait times went down in half. Half, not 2%, 5% improvement, half. Capacity went up 15%. The nurses were now taking their lunch breaks. And everywhere they were saying, how can this be? We're seeing more patients, we're doing more treatments, and it's no longer chaotic, it's moving smoothly. And that's when we realized we'd solved a very hard problem. And that was one cancer center, 50 chairs in 2013, 2014. Today, it's 800 cancer centers, 16,000 chairs. 35% of the chemotherapy capacity in the US is delivered on a schedule optimized by our platform. So that was the magic of it.
Amazing, amazing. I mean, I myself, as a hospital operator and then the CEO for more than 25 years, this is a daily issue for us. And the same question what your friend has asked you, I'm looking for someone to ask. I couldn't find a Mohan in this part of the world. But then, I mean, it is a fantastic thing. I mean, what you have done over there, because in also a couple of discussions, you, I mean, said one thing. It was very important for me. You said that the US healthcare is the best. We know this. I mean, Newsweek keeps reporting things, and the clinically, I mean, hospitals are amazing. But the area where I think we're failing is the non-clinical part. And we need a brain like yours. We need a company like yours to understand that. I will come to the more details about your business, how you manage it. But I want to go back to your book. I mean, in your book, you were saying that getting an appointment from a hospital shouldn't be harder than booking a vacation, which is a fantastic thing in my mind. But then you often compare also the operating theaters to a 747. And why is that an airline can coordinate 1,000 flights a day with almost 99.9 precision, but a hospital as us, we struggle to start our first surgery on time at 7:30 a.m. morning.
Mm-hmm. Well, healthcare, as I said, is clinically very sophisticated. If I think about things like robotic surgery or genomics or proton beam therapy, this is magic. If somebody had told you 10 years ago it would happen, you wouldn't have believed it. So clinically, it is brilliant, and it is just stunning what is possible to accomplish. But operationally, we still operate like we're 50 years ago. Two people chat and make an appointment. Nurses count heads in beds, write it on a piece of paper, and go to a huddle report. Surgeons fax their orders. So operationally, the complexity hasn't kept up. So the simplest way to think about it is, in 1940, Delta Airlines had 2 flights a day. 2. From Atlanta, one went west and one went east. You know what airport operations was? John, take gate 1, Bob, take gate 2. And John, your flight's running late, go help Bob. That was airport operations with 2 flights a day out of Atlanta. And it was brilliant. It was adaptive. It dealt with late flights, etc. Today, it's 1,000 flights a day out of Atlanta. The John, go here, Bob, go there doesn't work. So they have built the complexity and the sophistication to understand gate loading, arrivals, departures, baggage holds, how many tows, tugs, ramps, lifts, people you need, how the conveyor belts need to move the baggage, how does boarding work. They've understood all of those processes and built them mathematically and at scale, right? But somewhere along the line, they moved from the simplicity of a John go here, Bob go there to this. Healthcare is still doing spreadsheets and trying to solve that problem without recognizing that 50 years ago, clinical care was a physician with a briefcase who went to someone's house. And it's much more complicated today. So you can't schedule it by 2 people chatting, looking at a calendar and saying, Dr. Gul, Wednesday at 10 o'clock. That's how you schedule a tennis court. You cannot schedule something complex. And so the whole premise of what we're saying is the complexity in the sophistication in operations has not kept up with the growing complexity. We're still solving it as if it were 20 years ago in complexity. And that's why we need new methods.
I can't agree more, Mohan. I mean, the thing what I have noticed as a physician, previously we were writing all the notes on the notebook, the large notebooks, and then we were keeping the data. I think what we did, we simply digitalized the old models into the new EHRs by thinking that we're bringing a technology solution. And another thing, what I have noticed, our hospitals, they invest a lot of money into these kind of EHR solutions. And then we expect our electronic medical, recording system to sort all these things, because when we go to the chart over there, we expect the chart to talk us, but instead of just talking to us, it just opens the things openly over there, completely blank page, and our nurses, they just fill it. So, and another point, when I go to my shareholders or the chairman asking them, look, my HR has such things, and I want to sort with this kind of additional module that I want to buy, they always tell me that, look, we're already spending a lot of money on this software. Why should I buy something else? Why should I work with another company? So how are you going to, at the moment, how do you explain these things to your clients over there? And how did you achieve getting this much of clients?
Oh, this is a common conversation because the EHRs did something magical, which is, and by the way, they did it 45 years ago. The EHR company started in 1979, so they're not new things. They took the paper record and digitized it. That's very good. And it was very important. But they just went to dashboards. And they're a good system of record. They're a very good database. They're not a source of optimization. They're not a source of operational intelligence. They're a system of record. And they're excellent at being a system of record. And so every financial officer has this issue. We've already spent so much money. But that's the sunk cost fallacy. That's like me saying, I spent $40,000 buying a car. Now my kids want to learn how to water ski. So here's what I'm going to do. I'm going to drive the car along the side of the lake and teach them how to water ski that way. No, I need a boat. It's a different problem.
Indeed.
So just because you spent money on one thing doesn't mean it can solve everything. It cannot. Secondly, the EHR companies have tended to make health systems believe that they can solve all the problems. And they cannot. They just don't have the expertise to solve all the problems. They haven't spent 20 years helping airlines and helping logistics companies. They don't understand operations at scale. It's a bit like, imagine 25 years ago, if we had said, IBM will solve all our internet problems and IBM will deliver the internet of the future for us. IBM's a great company. They're still very relevant. They're doing all kinds of things. But the internet is delivered by 20,000 companies, 19,900 of whom were not even born 10 years ago.
True.
So it's a mistake to believe that the legacy vendor of the past is going to deliver the future. They will not. And so the HRs have done a great job. They will be relevant forever or for a long time as a system of record. But if you're counting on healthcare innovation to come entirely from them, it's not going to. So EHR first is a good strategy. Only EHR is a losing strategy.
Very true, very true. And we live this on a daily basis. Now, I want to just move to something practical. I'm a hospital CEO, and every day morning I have my own huddle. And then in the huddle meeting, we sit together with our leaders and we go through the things. As a CEO, my job is always to push and recommend something, and always they roll their eyes. Oh, again, he's recommending something. So now, practically for us to understand, I have infusion center, I have so many beds. It's always difficult. So what is the magic thing you bring into the discussion, and what do you do to bring us the efficiency? Can you just explain us in a physician level that I can understand?
Okay. Let me start with analogies to make it come to life. Okay. So think about the following. Delta Airlines has 5,000 flights a day. Okay. 5,000. Every flight, let's say, has 200 seats on it. So there's 1 million seats a day. You can buy your ticket 300 days into the future. 300 days. So there's 300 million seats up for grabs. Okay. Every minute of every day, Delta Airlines can tell you the supply-demand balance for every one of those 300 million seats. They can tell you right now that the October 1st, 7 a.m. Jacksonville to New York flight is running hotter than planned, meaning more passengers on it than they expected. You know what that will tell them? Don't offer discount pricing. Don't offer free award travel. Okay.
Well,
Conversely, if it was running worse than planned, they would discount the pricing to boost the demand up. So they can tell you the supply-demand balance with that level of precision. Now, a hospital cannot tell you what's happening tomorrow. So first off, you've got to manage the supply-demand balance of every asset with mathematical precision. So that's kind of thing one, right? Thing two is think about a passenger traveling from Doha to San Francisco. So there's a Doha to London, London to San Francisco, right? So every airport, you have to have connecting times, you have to move through. For that to work, you have to know the connect time, the probability of the flight being late. Is the distance between the arrival time and the departure time sufficient to make the flight? They understand all of this. It's very similar to a patient. A patient goes to the ED, ends up in the OR, ends up in a bed, goes into rehab and leaves. So it's like bouncing through all the airports. Now, when you bounce through multiple different points, there are entire classes of mathematics on it. Topology theory, network theory, graph theory. Hospitals do none of that. Hospitals just make up the itinerary. John, your appointment's at 9, come at 8 and do the lab, and we'll try and get your procedure done at 10. Nobody ran any topology optimization algorithms. And so because of that, you get bottlenecks. You get the same choke points. And it's like having the same traffic jam every day but doing nothing different, right? And that's the magic of it. Now, again, traffic jams are solved problems. Today, I mean, how did you solve your traffic problem 20 years ago? You didn't have navigation in the car and you didn't have a phone with a map. You got stuck in traffic and you said, oops. And if you're lucky enough to know your way around town, you took an alternate route. Today, none of us put up with that. If I know I've got an important meeting in New York on Friday, right now I will look and say, how long will it take me to drive from JFK to Manhattan at 8 a.m. on Friday, and plan accordingly. So we can predict traffic, even though it's highly uncertain. We don't know who's going to be on the road. We don't know if they're good drivers or bad drivers. We know none of that. And still we can predict it. Hospitals accept that you cannot predict and live in a reactive world. Every day they wake up to the same crises that could have been predicted. So now to apply that to how we think about it. What happens, take a 400-bed hospital with a 5-day length of stay, a 4 or 5-day length of stay. So every day they're discharging 80 to 100 people, okay? What they will do is they'll wait until they get stuck, and then they say, oops, we need to accelerate John's discharge. We could have predicted that. We could look at who do we think is going to be discharged tomorrow. What tests do they have scheduled? What test is usually required for this kind of a patient? So that you don't wait until the last minute and say, oops, I need a CT scan, and now try and squeeze a CT scan in. You could have predicted it. And if you can predict it, and now you predict the incoming volume. So imagine at 6 in the morning, I can tell you with great confidence, Unit 2 will be 2 beds short at 2 p.m. this afternoon. At 6 in the morning, I'm telling you that. Okay?
Amazing.
Now, of your 100 discharges, they're all important. They're all equal. Unit 2's discharges are a little more important, little more equal. So now you look and say, all right, how do I get 2 people out of Unit 2? I need to get Bob and John out. This guy needs a CT. This guy needs an exam. Can I move the multidisciplinary around? Can I move him higher on the imaging list? And magically, those 2 discharges happen. When 2 o'clock rolls around, guess what? Unit 2 wasn't 2 beds short. They had 2 beds.
What?
And so you're doing the equivalent of you're fixing the potholes before the car gets there. And if you do it right, nobody notices. The charge nurses are just working. The messages went flying. Stuff just happened. So healthcare is not about a smarter dashboard. It's about intelligent orchestration. It's sharp predictions, convert the predictions into recommendations, automate it so the actions happen without people doing a lot of things, and then the magic just flows. And it's just happened automatically. You haven't paid attention to it.
Beautiful.
Right?
I think we're getting back to the data management again, right? I mean, we have to collect all this data, and then we have to give someone like you all this data, because the last maths for us was just before the medical school. So then, I mean, you can help us on that and bring all these predictions. Then you can tell us what to do, when to do, with which physician. In fact, it is also affecting the patient satisfaction. When the hot season comes, I was just reviewing the Kresgeni data for our hospital. I'm sure you're also working together with them in US. All of a sudden, the summertime, our patients are very happy. And then September, October, when the season starts, people are back from the travels. Huge traffic is in the OPD clinics, and definitely waiting time gets, above the roof. Then all of a sudden, we see the satisfaction going down. So, with your help, I think we can secure and balance all these things together with this maths game, I guess.
Yes, patient satisfaction is driven by clinical effectiveness.
Correct.
So if I had a wonderful waiting room that gave me great snacks, but the doctor didn't solve my problem, I'm not happy, right? So you're happy when they solve the problem. But sources of dissatisfaction are often related to difficult to get an appointment, that's access, and you didn't do what you promised. You told me 10 o'clock and I was waiting until 11:30. Right? So ability to honor your promises and ability to provide access are big drivers of dissatisfaction, right? Now, having done that, you still need to deliver clinically, otherwise you won't get the satisfaction you need. So, assuming we're delivering clinically, what we are enabling is the operations, sophistication of the operations to catch up with the clinical brilliance. And that's how we frame our entire mission. We want to help our health systems become as sophisticated operationally as they are brilliant clinically.
Amazing. You were also mentioning a great word, the infusion Tetris, and you were describing the infusion center like the scheduling is as a game of Tetris, which I love it. Let's just focus on our charge nurse, let's say, in the infusion therapy center. When I approach to them, they always tell me that, no, I know my patients, I know very well, I can fill the time and the other things. But you described something like level loading. Can you explain this to our nurses? I'm sure so many nurses listening me, and we always discuss with them how to make the operations more productive and efficient. Let's
Yeah.
explain them the importance of this level loading.
So what happens is think of the freeways at rush hour, right? Now, at rush hour, the traffic didn't become 10% worse. It became 5 times worse. Something that should take you 10 minutes takes you an hour. A fender bender that should delay 10 people delays 10,000 people. So everything becomes much, much worse. Now, why is it magically okay on a bank holiday? Your commute time is half.
Yes.
Now, half the people in the world are not bankers. Only 5% of the people in the world are bankers. But taking those 5% off the road made life 50% better for everyone else, for 95% of the people. Why is that? Because they were the right people, the ones who work 8:30 to 5. You get them off the road and life becomes great for everyone else. So this is about mathematical leverage. You got to find the banker, which is the 5%. Now, a banker's easy. A banker yesterday is a banker tomorrow. But in healthcare, it's not so easy because every day it's a different set of patients, different set of doctors on things. So mathematical leverage matters. What nurses and operation and staff at hospitals don't understand or don't appreciate fully is how complicated it gets. Take a 20-chair infusion center that sees 50 patients a day, let's say. The number of ways in which you could have built a schedule is a number with more than 100 zeros behind it. That's how many permutations and combinations there are. Number with 100 zeros behind it. Think about it. A trillion only has 12 zeros behind it. And a trillion is a very big number. 100 zeros behind it is impossible for anyone to process. And so when the nurse or the frontline staff think that they can manually say, let me move this appointment from here to there, they're playing lottery on a scale where it's 100 zeros behind it. There is no chance they get it right correct mathematically. So what we're doing is level loading. So why does level loading matter? When you the reason you have rush hour traffic is you got a peak, and the peak exceeded the capacity of the number of lanes you've got. That's why it's completely jammed. If you level load, you're spreading out the burden. Imagine if you did the following. you made it a rule that only 10% of the people could work 8 to 5. 10% had to work 9 to 6. 10% had to work 10 to 7. Just suppose that was the rule. What you did is you spread the traffic out over a 10-hour period in both directions. Okay? Rush hour is not a problem anymore.
Exactly.
It works.
Exactly.
So obviously you can't do that in real life, make people work different hours. But we are doing the same thing for Infusion. We're taking the rush hour and spreading it.
Beautiful.
And then the flow is better for everybody.
I think the same thing can be also arranged in the dialysis centers, which we have huge problem. And then over there, the traffic is much more complicated. Some of the patients, they need the session 3 hours, some 2 hours, and we want to utilize the machines. And Arrow will allow us to operate even 10 hours, but all of a sudden we have the machine available, patients are suffering. So same thing could be applied for the dialysis centers as well.
It could. We have not done dialysis ourselves directly because of a couple of reasons. The math does better when there's high variability involved. Every day is different patients, etc. Dialysis tends to be a slightly more stable operation because once you start dialysis, you're on it for life. And people build it as part of their lifestyle. I come for dialysis on Tuesdays and Thursdays, and I come at the same time, and I'd prefer the same chair by the window. And so the center tends to have the same fixed customers who've established their schedule, and it becomes a routine. You don't have the uncertainty of the math around it so much as you do in infusion or surgeries or things that are, one-off things. And so it's easier to do a set it and forget it schedule in dialysis, and it'll be 99% right than it is to do in infusion. That's why we haven't done dialysis yet.
I know it is easy for you, but not easy for us. I know so many dialysis centers, my friend. They're suffering and people are waiting, and still, even this very much easy, predictable area, we're also suffering. So please
That's
talk to
interesting.
the
That's
dialysis centers as well. We have problem over there too.
Okay, I ought to look at dialysis a little more then. I haven't looked at it so far.
Multi here. So Mohan, I just want to move to the buzzword, this AI. Now, everyone became AI experts. Nowadays, wherever we look at the area, we're just hearing AI, and nothing else. I mean, when I looked at your company and the way how you manage the things, I mean, you're a role model, even with your company with 350 people. You're creating the AI work setup, and in one discussion, you were also sharing how you're letting your even salespeople going to the customers with the predictions and everything ready. So please tell us something as the healthcare providers we can learn from you, and then we want to hear your guidance on that because you're the maths person, which means machine learning and everything in data management. Then I want to jump to your IQ story, which I loved to hear.
So we think about AI in a bunch of areas, right? So there's clinical AI, which is helping physicians predict, do diagnosis, recommend treatment pathways, and so on. That's not what we do. We're not clinically sophisticated around it, so we don't apply our AI in that. However, we can apply some amount of it. So I'm not saying it's not zero, but it's more contained. We can apply our AI algorithms a little bit to do pattern matching and pattern recognition, where we say, we have seen these kinds of patients treated by this physician for this condition before, and they've invariably ordered the following tests. Now, you haven't ordered those tests. Maybe you want to think about ordering those. So we're not actioning it, but we're surfacing it. So to us, that is a very helpful use of AI, where we are identifying a pattern that a human being either could not do or does not have the time to do. Because you can't expect people to read hundreds of pages before seeing every patient, right? And so we're starting to do that. Operationally, there's a lot we can do because we can detect trends, and we've been doing AI long before AI was cool. We've been doing it for 10 plus years, right? So we are predicting, etc. Where we contain it is we want to keep the data set tight so that the predictions don't hallucinate and go somewhere else. So we contain it very, very tightly. The simplest way to think about it is, if you want to predict the traffic in Doha, you can't average London traffic and Barcelona traffic and use it to predict it. So you need to stay with the patterns of traffic in Doha to predict Doha traffic, right? That's what you have to do. So that's kind of how we are thinking about it as well in how we optimize them.
Amazing, amazing. So the next point, I want to ask another question. The shortage of nursing and healthcare professionals is a huge issue. Can you imagine every day morning when I come to the office, I receive emails, oh, doctor, you know what? I have received a job offer from this Western country, this Western place. And sorry, I'm leaving the UK, Canada, or New Zealand, or some other places, and shortage is something, it's a pain in my stomach, and I don't have a solution for this. And we are trying to find new places to hire the nurses. Nowadays, we are hiring from Nepal and then another place. So we are in a treasury hunt, unfortunately, and because of this issue every day. But then when I look at the AI, we considered somehow AI as a solution to that. And there are some critics, people say that, you know what, AI will squeeze the people for more productivity. But in your book and in your conversations, you kept saying that the better math actually reduces the burnout and then helps people to work better. So, can you please explain that? How do you argue this?
Well, the reality is the following. If you look at all the work that your nursing frontline does, 30 or 40% of their work could have been done by a 10-year-old. Okay? They spend 30 or 40% of their time pulling this number, sending a text message to that person, printing this report. Uh, that's manual work that if you got technology to do it automatically, then you free up their time. When you free up their time, they do things that only they can do. Hands-on patient care, etc. So when you use AI to automate mundane tasks that are not fully up to their license levels, then their satisfaction goes up because nobody became a nurse to copy numbers from a screen to a post-it note, right? Nobody did that. So you're freeing up time to do the more valuable things. That also unlocks capacity. So for instance, when we're doing the routine screening phone calls for readiness for surgery, nurses have to make 100 of those phone calls. They don't have time. So
True.
if the AI, if we've segmented it correctly, not taken the high clinical risk, done the routine ones, they can focus on the more complex cases where their expertise is needed. So then they feel that the phone calls they're making are high value phone calls that are respectful of their training and their expertise. So thinking of AI as a replacement is not the right model. Thinking of it as an amplifier and an enabler that lets everyone do what they are best at doing that the AI cannot do is just makes it a clearer win for everybody.
I totally agree. I totally agree with this, and I appreciate sharing this. So, a couple few more questions, if you allow me. You also have mentioned the black box in your book, and then you now the customers, the clients, the ones that are working with you from time to time. I'm sure they have such discussions with their physicians, telling them, "Oh, you know what? The algorithm now gave this time away." And then they have to explain this to them. So how do they explain this to the doctors? Because doctors are also, I mean, very intelligent and very emotional creatures. So very difficult to make them happy. How do you coach your clients describing and having such conversations?
Well, doctors are fact driven, so data matters to them. They're competitive, um, and they start out wanting to do the right thing. So all of the negative behaviors that happen are because of what the system did to them. The reason they hoard block time is not because they want to be bad people, but because the 10 other times when they needed to squeeze in a surgery, they couldn't find time. So they have a, I'd better hold on to it just in case I need it mindset, right? Now, if you unlock it and persuade them that, hey, whenever you need time outside of block, we can find it for you and we'll find it for you within an hour, suddenly they're happy to be good citizens around it. If they don't understand why the recommendation was made, but you can explain it and have the logic as to why it happened. So it's a transparent algorithm around it, and you can explain the decisions that were made and why they were made. They're reasonable people. So we put teams on the ground with every customer. We don't have a, I'm sorry, the algorithm did that, because that will never work with physicians.
It will not. You're right. I mean, you remind me just one discussion yesterday morning. We're working with an outside clinic, and they have amazing star physician, and she operates in my hospital, and she always wants to operate on Monday mornings. She's a dear friend, and we're telling her, look, Monday morning, it's a very busy time. Can we just shift a bit? I mean, I cannot say AI or algorithm. I don't have such things in my hospital yet, but it was not an easy conversation.
No,
Uh,
so the problem is everybody wants the same time slot. That's the thing.
always. Mohan, I mean, as I said, I read almost half of your Better Healthcare Through Math book. If I mean, listeners want to read this, which chapter do you recommend them to read it? It's a must to read. I mean, like the chapter 4, I think no block left behind. It was a very important chapter. But which one is your favorite?
Well, we wrote it asset by asset because we felt surgeons would care about the ORs, cancer doctors would care about the infusion chapter. So we wrote it asset by asset. So we set it up in the front with a why is this problem there? All what we talked about at the beginning, which is clinical sophistication, operational sophistication, etc. And then we went asset by asset, and then at the end, how you make it work. So I guess the chapter that would speak the most to anyone would depend on what their area of interest is. But we're moving beyond that, though. We're going to we've taken all the concepts of air traffic control, airport operations. Where we are headed with our AI, and now we are capable of doing it, is a mental model of what I'm calling a central nervous system. Okay. And what do I mean by that? Think about how a central nervous system works. If you touch a hot stove, what happens? Your fingers detect the heat. Before it goes to your brain, your spinal cord clenches your fist and pulls it away. Then 2 minutes later, or 2 seconds later, your brain says, ooh, that was not a good thing. And you've learned to never touch a hot stove again for the rest of your life. So in the space of the 2 seconds, you sensed an event, you made a decision, you pulled your hand away, you acted on it, and you learned for the future. All happened in 2 seconds. Imagine if we did that in healthcare. A patient presents at the ED. We're predicting, we're saying what's going to happen. We're predicting this patient's going to need a bed in the pulmonary unit 3 hours from now. We're starting to create that pulmonary unit. And that's what we're doing from the very beginning, right? And then acting on it. But in order to do so, you have to gather the signals and never lose the signals. Healthcare loses thousands of signals a minute. Every minute something is happening. There's some med device that has read a number. There is something that's happened. And we're evaporating all that knowledge instead of learning from it.
Unfortunately,
Right?
unfortunately, I mean,
Think of what Facebook is doing. Every time you click on anything, they learned who likes what they do. And from that, they're forming affinity patterns. They're learning. They're putting the right articles in front of you, etc. Good or bad, I'm not passing a judgment on it. They're learning from it and doing things with it. That's what we're doing. We're migrating towards operational excellence run like a central nervous system.
in future, do you think the hospital operations center will be run by human or with self-healing algorithm? I mean, do you think I will have a CEO job in 5 years? Otherwise, I can go back to bedside management.
I think more and more intelligent operational decisions will let operators deliver the true potential of their system. Right now, operators are fighting with blunt tools. What I always think about is McEnroe won Wimbledon playing with a wooden tennis racket. Can you imagine how you'd have played if you'd given him a graphite tennis racket to play?
Yeah.
So we just need to give people graphite tennis rackets.
Mohan, thank you very much. I mean, I really enjoyed, as I said, this was a wonderful lesson for me. And then, I mean, I teach the future healthcare leaders in London and UCL. I will definitely mention, and I would love to also have you even virtual in one of my lessons.
I would love to. I do that for the Mount Sinai Master's Program, or I've done that for a few others. And At least it's ready. You don't have to make it virtual. I'll be happy to come out.
Perfect. Perfect. And we should plan it and then we can spend more time together.
Sounds
Thank
good.
you very much again. I mean, for your time, for your great conversation. So I really enjoyed listening to you.
Terrific. Thank you for inviting me.
You definitely, I mean, reminded us about the operational excellence issue, and it's not a luxury, it's a clinical necessity. And you just said that clinical necessity success will not work without this non-clinical part. And I want to also encourage my listeners reading the Better Healthcare Through Math book. I'm sure they can find it on Amazon and other places.
You can get the audio version, you can get the electronic version, you can get the hard copy, you can get whatever you want.
Excellent. Mohan, again, thank you so much for being here with me and on the Chief Healthcare Officer podcast. I really, really enjoyed this conversation. Thanks again. Thank you very much, my listeners. Tune in. I mean, we will have so many other guests, and I would love to invite more and more great guests and have more discussions. And happy to have you here. And thanks for your time listening to this.